So while the slides are being put together, I'd like to first of all thank for that very kind introduction, also having me here, to Professor Wimberg and also to Professor Licht and also to Lars Kessing, who's a very good friend. And it's really nice to actually see people in their usual circumstances in their home. I've also had a 2-hour session today with some of the people doing PhDs, all very bright young minds, and I've been told that there's about 30, almost 40 people in the department who are doing research alongside 4 professors. A really impressive effort and quite magnificent to see such a concerted effort around some important problems for mankind. This is the only way to resolve them, is to have really the best people working on them. So thank you for having me here. It's a real privilege. I've been a fan of lithium and by extension a fan of many of the people who've done pioneering work in relation to lithium, and also been fortunate to have met quite a few people who are directly working on this, particularly people such as Sam Gershon and Paul Groff. Unfortunately, I've never met Professor Skau himself, but one of the reasons I wanted to come along was he's made a huge impact on the field, and it's great that you're obviously very proud of that and also wanting to reclaim the authority around lithium and where the advances have been made. Now, I'll prefix my talk by, you saw the lineup, we've got fantastic people here, people I have a huge amount of respect for. Janusz, for example, who's going to be talking immediately after me. And all the people are going to give a perspective on Mogen's life. So I'm not going to dwell too much on that. I'm going to touch on a few things, but I'm talking mainly about lithium itself, so that there's not too much duplication between what I say and what others are saying. Now, why I also jumped on a plane and traveled 32 hours to be here, you might be wondering, is that I get invited to do a lot of talks about all sorts of aspects of my research, but I've never ever been invited to give a talk to this title. When they sent me this title, I had to refresh my browser and look at the email again. I said, really? You want me to talk about the king of mood stabilizers? I didn't think of that title. Was that yours? I mean, fantastic. I mean, that is how you hook a fish. You know? It was beautiful. I read that title. I said, even if this was on Mars, I would be going. Right? Because it's beautiful. It's a great title, The King of Mood Stabilizers, you know, and I'm really very impressed with that. So this is obviously celebrating a huge achievement in terms of his life. I'm obviously quite conflicted in terms of my roles. I have grants for all sorts of research and also do things with pharmaceutical engagement. But you'll notice one thing, I don't have any conflict of interest with lithium, because no company sponsors it per se. There's no real funding for lithium. It funds itself. And that's what I'm going to be talking about today. So what do I do? Just to give you a little bit of an elaboration from what Professor Wimberg was talking about. I, like any young boy, wanted to be an astronaut. But failing that, you have to have a plan B, C, or D. So this is my plan E, which is what I do. Okay? So I do research. I have editorial roles that you mentioned, I do teaching, and I have clinical work. And I'm just going to quickly whiz through them. So this is my team, not exactly 40 people, so I'm very envious of the number of people you have. But what I can say about my team, and I say a decade, because it's been 10 years that this particular group have been together. This is our core team. We actually have another dozen or so people in terms of students and part-time people. And without them, really couldn't do any of the things that I do, both clinically or research-wise. So while I'm here claiming, you know, all these advances and insights, and it's fun to be able to do that, there's a lot of people who work alongside me in that capacity. Now, in addition to the clinical research, one of the things you need is tools. And in terms of research, we've been very fortunate in arguing that our university invest in the latest technology. This is a 3 Tesla Siemens scanner, which is due to be upgraded in a couple of years' time. But we've already had 10 years of exclusive use of it. And in an Australian context, it was a unique machine because it only did research. And because I was able to argue strongly for it, it only did mental health research. So you can imagine how rare that is in the field, to actually have full access 24/7. And what it's allowed us to do is really innovative research, because we're not fighting for time. So I'm going to present that right at the end of my talk. In terms of my editorial roles, just following on with the students who I was talking to earlier, I'm editor of 2 journals. One is the Australian New Zealand Journal of Psychiatry. The other is Bipolar Disorders, which specifically looks at bipolar disorders. And both journals are doing very well. but they take a lot of my time. I also publish in terms of supplements and ACTA, your local journal. I've published many supplements in that, and I understand your editor is also taking very senior roles within the societies and championing research here in Copenhagen. And relevant to today's talk, I published this book about 3 years ago, Science and Practice of Lithium Therapy, with Marc Masson and Franck Bolivia. And this came about after a discussion, as often things do, in a cafe in Paris, where we were all sitting around and saying, wouldn't it be great to have a book on this particular topic? And lo and behold, as soon as I got back to Australia, I got an email from the two of them. And I think it was really, I should have seen this coming, because both of them are French and somewhat devious. And so they sent me an email and said, Jin, we'd like you to drive the whole project. And you can be the first author if you want. And essentially this became my headache. But actually, we managed to bring a huge number of people together. It brings all the contemporary knowledge around the science and practice of lithium therapy together. Another role that I have is in terms of guidelines. So as chair of the Australian-New Zealand Journal of Psychiatry Guidelines in 2015, which published around mood disorders, and then subsequent summaries which have been published in the Medical Journal of Australia. So, in terms of clinical role, I named the clinic that I started about 10 years ago after John Cade, partly because obviously he's Australian, but also because his name lent itself to this acronym, Clinical Assessment and Diagnostic Evaluation. And I spoke to his son, Jack Cade, who's an intensivist in Melbourne, and said to him, look, I'd really like to use your dad's name, and your name obviously, for the clinic, and he was very supportive of it, and we published a brief article around it. And since then, it's been really useful to have someone like that champion a cause. So you need people who have a vested interest and obviously popular in that area, and I'm sure the same applies locally here with your own champions. Who is seen at the clinic? Just to give you a background of where most of my research comes from, I deal mainly with adults, including elderly patients, adolescents from the age of 16 or so, both inpatients and outpatients, and also the types of disorders obviously include depression and bipolar disorder, but also personality disorders and anxiety disorders. And what we do, a number of things. I've mentioned imaging already, but in addition to that, we do provide second opinions and also involve virtually all of our patients in the research that we do, which spans not only imaging, but neurocognition, therapeutic trials, genetic, neuroendocrine, and physiological studies. And we also provide detailed liaison for the hospital itself. So it's quite busy, and the clinical assessments usually take anywhere between 2 to 3 hours or so. They're usually single assessments. We don't have the resources to follow up. New South Wales is quite a large area, and so we often see patients once, and then we refer on to other people around us. So, to be more focused, more recently, only 2 years ago, we started a lithium clinic specifically because we were seeing this huge range of patients. We wanted to narrow down to lithium itself, and we started this. Now, the reason I emphasize this is that it's the only clinic in Australia. You might find that astounding. In Europe, this is quite a common model, where you have clinics dedicated to lithium. And I trained in the UK right up till my sort of senior lectureship, and then went to Australia. So it was a real shock to me to find that one of the places which really should be championing lithium doesn't even have a lithium clinic. So it was an obvious opportunity to start a clinic of this sort, and we've now managed to do that, and we provide assessment for patients who are exclusively on lithium and all the various aspects that follow with that. So that's been also very important in informing our research and what we've been doing. This slide really talks to the fact of my obsession. So a couple of years ago, on my birthday, my team made a cake out of lithium. And they put this on top of it, this atomic element alongside it. So it just shows that I'm afflicted with this just as much as anyone else. And it shows that you have to have passion for it. Okay, so I can all see you thinking now, time to start talking. What do you know about lithium rather than about yourself? So let's move on. So this is what we're here for, to celebrate the achievements of these three gentlemen, and in particular, these are all familiar to you, I'm sure. And I'm not sure where this picture was taken. I was going to actually ask someone who might know.
In 1970.
Uh-huh. Where was it, though? Somewhere locally here?
In Aarhus, probably.
Right.
It was 1970.
1970. Beautiful. And it's a unique picture, isn't it, bringing the three of them together? I think I couldn't find any other documentation of that at all, or any other picture of it. And it shows how things are together. Obviously, a common interest bringing them into that sphere of research. So what is lithium? Well, I like to think of lithium as our oldest friend. And the reason I've picked this picture is research is showing that really after hydrogen and helium, lithium was the first element, solid element, to be formed in the Big Bang, so probably within milliseconds of the universe being created. So it's been here a very, very long time, and we've really evolved around it. And you need to bear that in mind. It's not something that's been concocted by mankind. And the reason I emphasize that is nowadays, the term natural is used so widely to describe a whole range of things that have no efficacy whatsoever. But actually, lithium is natural. Lithium is a natural element. So to label it as a medication, label it as a pharmacotherapy, label it as a drug is somewhat disingenuous. A lot of other agents, which are probably more manufactured as vitamins and so on, which don't exist naturally in other states, are probably more like pharmaceutical agents than lithium is. That's an important thing to bear in mind. People who take lithium do think of it as a medication. And yet, one could argue only the dose is different, but in fact, it's not that strange to be taking something which essentially exists in a very similar form around the world in various parts of lakes and so on. This paper I wrote with Sam some time ago, and it's important because it shows how the history and evolution around understanding lithium goes way back into the 19th century. And there again, there was a very strong influence from the Danes. Important. And I think I've seen this argument go back and forth in some journals, where the Lange brothers really did some pioneering work in putting lithium on the map. And then there was this huge hiatus from 1900 or so, right through to 1950, before John Cade once again published his seminal paper. So half a century or so was lost, where people took interest into other things. And one of the reasons was obviously antibiotics came along. There was the whole idea that microbial pathogens were underpinning all sorts of diseases. And so perhaps people moved away for a short while until once again there was a lot of interest. But if you look through this again, apart from that early influence, here there's a large chunk of time where you have, once again, a very strong Danish representation in putting lithium on the map. And it's really quite important to bear that in mind. So I think lithium is the king of mood stabilizers, but the question is there any evidence for that? One thing to have a belief, one thing to have a passion for something. What we're really wanting to know is that the case? Now, a very cursory look at guidelines, which is quite remarkable, shows that lithium has an indication first line across mania, depression, and other forms of the disorder. This is a slightly older paper from about 5-6 years ago, but the thing hasn't changed much. And that's really quite remarkable. When I mentioned about my conflicts of interest, we've got to remember that a huge amount of effort and money has been put into promoting other agents. That hasn't happened with lithium at all. Not at all. And yet, it remains first line, and certainly very prominent in guidelines. That must be saying something about its efficacy and its utility, something about its basic ability to improve some aspects of the illnesses that we're looking at. Taking on their analogy of the king once again, and looking for what the justification is, it's actually been in good company. So this is the Centre Hospitalier Sainte-Anne, where Jean Delay and Denneker in 1952, I think it was, discovered chlorpromazine. And they have a wonderful library. And this is Marc Masson, who I wrote the book with. We looked into the history of lithium and published an article about lithium having an element of blue blood and its history in terms of why it has been such an important element in the broader pharmacotherapy of bipolar disorder. So I would say it retains its throne for these reasons. This is why it's such a key element. Firstly, as I said already, despite extensive marketing from Big Pharma, it remains in pole position for most guidelines. It's also used very widely in bipolar disorder, but also as an augmentation strategy in depression. So when depression gets to the point where you're getting non-response and you're having difficulty in getting an optimal outcome, lithium is the most widely added agent. So all of these things, I think, speak to the fact that it has an intrinsic property that we don't fully understand perhaps, but clinically and empirically, it seems to prove itself time and time again, and hence why it retains that role. But what is it that gives it this sovereign right? That's just really still descriptive. We look at that and we say, okay, it works, and it's in guidelines. Can we actually peel back something further and try to understand what is it that really sets it apart? So we've had a research boom in the past few years, and many people would argue that that started in the late 2000s, but 2010 was a key publication, the balance study in the Lancet by Geddes and group, who tested utility of lithium in a real-world setting against another anticonvulsant, namely valproate. And since then, and alongside that particular study, it's spawned a lot of interest, both clinically and in basic science research alongside lithium. And it's basically reinforcing our views from earlier research. But this has been really important in terms of having a confluence and a critical mass around lithium. The other reason I think it's quite unique is that we can actually measure its blood levels. Now, when I'm teaching around this, people often say, well, you know, patients don't like to have blood levels taken, or they don't like needles, and that's true. But at the same time, we have been sold this myth that there's something beautiful about not measuring, about not knowing. So a lot of the other agents, we're actually prescribing blind. We have no idea what the actual levels in the blood are. Yes, there's been some preliminary studies in animals and then sometimes studies in trials, but then extrapolating that to the general population with all the other circumstances changing is quite a big leap. And yet we prescribe those agents purely on the basis of what we know from that very small sample initially. We never measure it again. So most of the medications used in bipolar disorder at the moment, for example, putting aside the anticonvulsants, the atypical antipsychotics hardly ever get measured whatsoever. I actually think that the fact that we can measure lithium is a huge strength. We can actually know how much there is, monitor its utility, monitor its side effects, and so on. So this is, again, something about whether or not it's a unique property or not. It's certainly an important property that we need to amplify. The other thing that's not really talked about too much, and certainly it hasn't been championed, is its two unique properties of A, being anti-suicidal, and B, having neuroprotective effects. And so it's now being utilized, or at least explored, in the context of cognitive impairment. And I think in anti-suicidal property, that's a really untapped area altogether. We don't have agents which are specific to suicidal tendency. And we need to understand that better. So here we have a very simple element that is not only utilized well across all the spectrum of mood disorders, but actually has benefits in other areas as well, and can be measured relatively easily and safely. So it seems this is what really should be setting it apart. But there's another aspect of it, its specificity. It does seem to target a certain population. But I'll come to the confusion that's been caused in the field and why perhaps lithium hasn't achieved total dominance in clinical practice as it should have, particularly in North America, particularly in other parts of the world. Maybe it's utilized a fair bit in Europe, but certainly not the case everywhere. So in terms of specificity, one of the key questions is, who does it work for? What does the patient who has a good response to lithium look like? Now, obviously, we're doing genetic studies to try and see a profile of that. We're also going to talk about some imaging studies in that realm. But clinically, this has been known for a while. Patients who have very recognizable episodes of illness, they also have a pattern of recurrence, and they have clear periods of remission in between. These are the patients that time and time again, over follow-up studies, longitudinal studies, have shown that they respond to lithium. I'm just going to look at those three characteristics very carefully. Why recognizable? And what I mean by that is that they have a clear depressive episode with melancholic features. The mania is also a typical type of manic presentation, where there's euphoria with clear behavioral concomitants you'd expect with mania. These are pure forms of the illness, very little or no comorbidity whatsoever, and there's no mixed states or confusion around the symptomatology. These are the patients that do really well with lithium. So even just profiling them at a very basic level in that way, you start to pick out those people that will respond better to lithium than not. The other 2 points I mentioned were recurrence and remission, pattern of illness. And this is probably more important than the poll. And what I mean by that is whether they've got mania, whether they've got predominance of depression, what mood state they're in. We've really lost that longitudinal perspective in mood disorders altogether. Initially, they were defined purely by the idea of recurrence and long-term recurrence, but now it's more cross-sectional. It's to say, have they got these symptoms at the moment that meet mania? Have they got these symptoms that meet depression? We don't take that historical perspective. But the pattern is probably the most important aspect that determines whether or not they're going to respond. And the remission in between episodes is vital. And so it must disappear for significant periods of time. And why? Because it probably demonstrates that there's some intrinsic ability of the brain to remit, be it spontaneous or be it in response to treatment. And that probably speaks to the mechanism of action of lithium and why it sets it apart from antidepressants, atypical antipsychotics, and anticonvulsants. Having that ability that there is full 100% recovery and functional impairment is lost altogether. So they're really back to where they were for even a brief period of time. Now, I wrote a little bit about this in terms of why lithium is important and why it might be useful as a tool to carve bipolar disorder. So all of this about the specificity of lithium, what use is it to us? I said we can profile patients clinically, but if you think about it, one of the things I've been talking about this afternoon, a lot of the students were doing randomized controlled trials and other things. How we bring drugs to market is we look at a population, we try a new agent, we do a randomized controlled trial to see if it's efficacious or not. If we knew that there was a subset of people that responded to drug A, you could actually remove them from that sample. At the moment, everyone goes into the trial, and there's a lot of noise. You don't have homogeneity of the patient population. If you took out lithium responders, you do two things. Firstly, you identify those people that are lithium responders. Secondly, you leave behind people who are non-lithium responders. And by virtue of that, they're more likely to be a homogeneous group because they don't have lithium responders amongst them. So this could be your first set, whereby you set aside people who respond to lithium versus that don't. And this would be a very nice way of actually stratifying the patients as they go into a trial. So you cleave off this particular group. And lithium is quite ideal for doing that. Because it's widely used clinically, you could utilize that so that you can actually have specificity to define, firstly, the diagnosis, as I said, separate a group of patients that respond, and more importantly, the remaining group, then you could test with other drugs, other medications, different mechanisms, and so on. But many patients don't respond to lithium. Not at all. In fact, sometimes the symptoms are exacerbated. What do we do about them, and what's the reason for that? Here's a Danish axe. I thought you'd like that. I'll throw that in just for the fun of it. Now, if we use that axe, we can cut ice with it. But not always. What's the circumstance in which we can't? So here we are. We can cut ice, but if it's liquid, it's the same molecule. Now it's useless. Same tool. But what's changed is the circumstance, the environment, the context. So lithium is the axe. It's the same tool. But where it's not working, in this instance, the environment has changed. So what has actually changed? Why does lithium not work in certain instances? And why do some people say that its efficacy is diminishing, that it doesn't work at all? Because they're using it for the wrong type of disorder. I'm going to show you a little bit about what I mean by that. So bipolar disorder, which we often talk about, is not manic depressive illness. Let me say that the other way around. Manic depressive illness is not bipolar disorder. It's not. What's the fundamental difference? Now, one way of comparing differences is, go around the world. Some people say, we say tomato. Other people say tomato. The other difference is tomato versus potato. Tomato versus potato. What is it? Is it just a subtle thing in pronunciation, or is there actually a contextual difference between manic depressive and bipolar disorder? I'm saying they're fundamentally different. I'm saying it's not a matter of pronunciation of tomato or tomato. It's actually comparing two things which are very different, a tomato and a potato. And the gap between the two is actually increasing. So bipolar disorder is not manic depressive illness. And I'm going to show you a little bit about why I think that's the case. One of the things is the lack of precision in the terminology we have for bipolar disorder. We've started off by saying it's the king of mood stabilizers. We understand what a king is to some extent, do we really understand what a mood stabilizer is? Have we got an understanding of that? I'm going to go through that in a short while. The other is bipolar disorder. It also has these other strange beings called bipolar 2. And I'm going to throw a little bit of a question mark around whether this terminology is accurate and useful. And finally, the United States has given us this mixed states. And again, we have to think about and question, as a blanket statement anyway, what comes out of the States. But in terms of mixed states, I think it has to have a big question mark as to what they're defining using DSM-5 at the moment. So let's go back to mood stabilizers, the teddy bears of bipolar pharmacotherapy. The reason I use that term is it goes back to Teddy Roosevelt. He was, all presidents had to be seen to be shooting and doing something and killing things and so on. And he wasn't really one to enjoy this. And so this was a setup. And one of the cartoons at the time depicted him in this way. And a toy maker who took an interest in this decided that they would make bears as toys. And so the teddy bear named after him was born. And it's obviously a likable personal companion. The personal aspects makes them special. And that's the same feeling that a lot of people have with the term mood stabilizer. It's comforting. It's a great term. Who wouldn't want to have something that confers stability? That's why it's so widely used, both by patients and by clinicians. But surprisingly, if you scour the literature, not one single agent has a formal indication for mood stability as a mood stabilizer. So all these drugs, which we talk about as mood stabilizers, don't actually have a written down indication as a mood stabilizer. They have it for various parts of the illness, but not as a mood stabilizer per se. Why is that the case? Mainly for marketing, mainly because people like the term and it's utilized. Does it actually help us clinically in terms of practice? Well, I would say the current mood stabilizers, most people would agree, lithium is in that grouping, but there's also others such as anticonvulsants, antipsychotics, and there's a question mark around antidepressants. Strangely, mood stabilizers is never used in the context of psychosocial interventions. So it seems to be constricted around pharmacotherapy for some reason. But the definition is quite difficult and varied. First, no clear idea of what mood stability looks like. So this is our goal. If you're prescribing a mood stabilizer, you have to have an end stage. What are you trying to achieve? Mood stability. So what does that look like? We actually have no idea. So there's no end point to the treatment of this agent. So whatever that agent of mood stabilizer might be, where does it lead you? We don't know. The focus has mainly been on acute treatment, when actually it's long-term prophylaxis that everyone clinically agrees is the key. Yeah? I think all clinicians who've seen lots of patients will say that is what we really want. We want that long-term prophylaxis, long-term mood stability. And yet it's not formulated. It's not part of our understanding of what a mood stabilizer should be. It's not captured in any definition per se. Some of the key considerations around mania and depression. Mania certainly defines bipolar disorder, but it's depression that's important in terms of the burden of the illness. Certainly in major depressive disorder, we find the commonality. And though acute efficacy is important in maintaining people's wellness, it's when they're well that we need to be focusing on them in terms of preventing further relapses. And that's where a mood stabilizer is actually doing its work, when they're out of hospital, when they're reasonably well. So those are the mechanisms that we don't actually understand what those agents are doing. And yet, if you look chronologically over time, how much time people spend on those medications, that's the majority of their life. They're on a medication. And they're not feeling unwell per se at that time. But clearly the medication is doing some benefit, one would presume. So what is that? What is it actually doing? So here we are. We need to emphasize the long-term versus the acute, and treatment of mania versus depression. And this is what a typical picture might look like. Manic episodes in the red going up, depressive episodes below, and a mood stabilizer leading to reduced frequency of recurrence, reduced severity of symptoms and episodes. That'd be great. More importantly, though, you actually get functional recovery throughout that time. So once they're on a mood stabilizer, they actually are much better overall. So this is building towards what we should be expecting of a mood stabilizer. And if it's going to be described as a king, then that's what we really need to be looking at. Question immediately arises, however, how long should it achieve mood stability? What's a reasonable time? And here, given some examples, 1 year, 3 years, 5 years, life. And it's actually life that we want. We want it to be able to work for a long period of time and maintain wellness over the lifetime of that individual. But most trials are relatively short, somewhere between 1 and 3 years, most of them, if that. 5 years is seldom tested. So again, we're not really testing or looking for a mood stabilizer per se. So a couple of years ago, started a number of groups. These are key opinion leaders in Australia and New Zealand. We got together, we had a mood assessment committee, and we got a little bit over familiar with each other. We formed a treatment algorithm group. This is what Australians and New Zealanders do behind your backs. So when you're not looking and you get 10 or 12 of them together, they can't wait to get together and do this sort of thing. What we were trying to do really was to define mood stabilizer. Can we find a definition or at least an approach that improves our understanding of the mechanisms? And we looked at the key aspects and developed a structured approach. All the things I've been talking about, maintenance and prophylaxis, were really more important than the acute stages. And it's this phase that really lithium is the best in terms of its efficacy. We already know that. And this is what would secure its title as a mood stabilizer. So this is from the guidelines. And one of the things we had in that was its ability to prevent mania, ability to prevent depression, the efficacy and tolerability of each agent. And as you can see, lithium stands out in terms of its efficacy. And it's somewhere halfway, but more so towards mania than depression. And that holds in terms of its clinical effects. Obviously, like many of the other agents, it has a lot of tolerability issues. So it's kind of got the clinical acumen, but this is very crude. We wanted something more sophisticated. One of the things we looked at more recently, again, was does it compare across all those areas? Anti-manic, antidepressant, prophylaxis against mania and depression. And again, it does well, but then so does another agent called quetiapine. And if you look down, a few of the other agents tick those boxes. But actually, not a lot of them do as well as these two in terms of having efficacy across all the areas you'd want. And particularly, remember, we want efficacy in the prophylactic area. The CANMAT guidelines published earlier this year in March, which involved an effort from a large number of people, and these have been revised time and time again and are very well received, again show that same picture. Particularly if you look at lithium and quetiapine at the top, you see there's the maintenance aspect that they both do very well in. Lithium falls a little bit short in depression, and I would agree with that. Clinically, in terms of acute depression, it's not fast to act, and it's not always as effective. That's the only sort of downfall of the agent in terms of clinical practice. Quetiapine seems to do quite well, but I would question its efficacy certainly in depression again, acutely that's to say, and certainly would question its efficacy longer term. But here, maintenance is being thought of as 18 months, 2 years maximum, not 5 years, not 10 years, certainly not lifetime. If we had empirical data, I think lithium would do extremely well in that regard. And then this is a chart which expands it at tolerability. And here you see lithium actually does quite well in terms of tolerability concerns against an agent like quetiapine. Tolerability around it is better. So it's on par with what we have in terms of antipsychotics. So the proposal we had was, why don't we try and look at a way of capturing this information in a way that's immediately obvious and also informs future research and clinical practice. And so one of the things we did was we developed a matrix in which you have acute and prophylaxis at the top, mania and depression at the vertical, and then you only have 2 settings, no effect at all, modest or significant effect, and you can capture what a molecule looks like. And if you look at lithium, in this perspective, it looks a lot better than something like quetiapine or lamotrigine. So even its closest agent, it certainly has a lot more efficacy in the prophylactic age. And this is published in this way, quite evident that this is closer to all 4 squares being completed as opposed to other agents. And this is what we need to be aspiring to, using this kind of rubric or metric to both measure the efficacy in trials and also present the data around these agents, rather than just looking specifically at a p-value or one particular aspect or one phase. So who can claim to be a mood stabilizer? I think lithium, you've pretty clearly I would put up on there, but others may be quetiapine and olanzapine just looking at the data. But they're intolerable. Longer term, the side effects from these agents aren't great. And maybe some of the newer agents. So what we're trying to do is make sure that maybe companies or others start looking at mood stability and also looking at mood stabilizers, meeting this more stringent requirement and being able to fill out that matrix more fully before and defining themselves as mood stabilizers. What about bipolar II disorder? Why did I have a go at that? Well, I think it's a very limited view of reality. If we look at the classification of bipolar disorders, all of you know this, so I'm going to skip over this relatively quickly. The distinction between the two is essentially around the duration and severity. So bipolar II, more than 4 days, but less than the 7, and the severity is less than mania. Otherwise, depression is the same. But it misses out quite a lot of things where people are less than 4 days, let's say, unwell, or there's a gradation of severity in between that. It doesn't capture that at all in terms of defining bipolar 1 and 2. This is what typically happens in clinical practice in people I see. They present with depression. They have a period historically or currently. Then they have a small blip of manic symptoms. Then they have another depression. Then they have further manic symptoms. Then they have a full-blown manic episode, further depression, and further manic symptoms over a period of maybe 7 to 10 years. And this may start in teenage or later on early adulthood and so on. This is defined as hypomania. This is as mania. But the problem is that in terms of the depression, whenever they're presenting to their GP or psychiatrist, they get a varied diagnosis. Here, cross-sectionally, they're diagnosed as having major depression. Here, on that story, they'll be given bipolar II depression. And here, they'll be given bipolar I depression. But it's depression. Only thing that's changed is the context each time. But it's important because that change is fundamental to treatment. By changing from major depression through bipolar II to bipolar I, we're told that the treatment changes and the disorder is the same, is different. But now when you look at this person here, it's the same person. It's the same illness. It was just evolving with time. And so we have a problem in terms of our diagnosis. We have to question, are we really treating the one illness? Are we getting it wrong? So one of the things I wrote about in this was why the hype about subtype, bipolar I, bipolar II, it's simply bipolar through and through. And I think we need to revise our description of bipolar disorder. So DSM-5, which is used very widely in Australia and New Zealand, uses this description that I've talked about, this distinction between hypomania and mania. But it doesn't really address short duration hypomania, people who have manic symptoms for 2 to 4 days. There is something in the appendices of DSM-5 which captures that. There's also these other episodes that they've got in the appendices, which they've kind of snuck in. They don't want to talk about them. And the main reason is, in the States, you don't get remuneration, you don't get funding, and you don't get reimbursement from the government, and you can't prescribe certain medications unless you have a diagnosis which is in the DSM-5. So you have to make it fit. So this is distorting our statistics, it's just distorting our epidemiology, it's distorting our ability to treat. Much better to just define all of it as mania and just describe the number of days the person has had mania. And maybe take the cutoff to 2, which all the empirical studies seem to show as a distinction between mania sustained beyond 2 days seems to be pathological as opposed to something that could have been either drug-induced or a natural variance. That would make much more sense. So this is just a proposal looking at that. But what it questions also is our understanding of bipolar disorder as a consequence of it. So my feeling is bipolar II at the moment contributes to the diagnostic instability that we have, and also risks us treating comorbid illnesses such as personality disorders, when in fact they need an altogether different paradigm of treatment. In mixed states, the question is, what is the target of treatment? I'll skip over that. Now, in DSM-5, we're told that we have specifiers, but it's a misnomer. They're not specific at all. In fact, they lack specificity. What's been put forward is that 3 symptoms from the opposite pole can specify a mixed state. And these are the other specifiers that DSM provides. Amongst these, you can color your mood episode with mixed features, provided you have 3 symptoms from the opposite pole. And so you can end up with major depression with mixed features, with a few manic symptoms, or you could have mania with a few depressive symptoms. You have mania with mixed features. So they're all mixed symptoms, all mixed features, everyone's happy, everyone's together. What's specific about that? There's no specificity whatsoever because those particular features are not specified. You can have any one of them. And if we look at the criteria for depression and mania, we see that some of these symptoms are overlapping. They're the same on both sides. So again, it's not clear what these mixed symptoms should be, which ones should be excluded. What DSM-5 has done is it's excluded any symptom that's overlapping. Rather than counting them once, it said that we're not going to count them at all. So there was a danger that you double count by having them in both sides, But now you're not counting them at all. You're taking out mixed symptoms because they're overlapping. And the ones they've taken out are distractibility, irritability, psychomotor agitation, cognition changes, and the neurovegetative changes. But there's a big problem with doing that. The overlapping symptoms, they're critical. They actually define the mixed state. They're the core. They're the truncal part of the tree. Without them, you can't have a mixed state. They're essential both to defining mixed states and for further subtyping mixed states. So you've thrown out the baby with the bathwater by taking out the overlapping symptoms. So the symptoms themselves, which I like to remember as DIP, distractibility, irritability, and psychomotor changes. These are really, really important symptoms. And most mixed state patients will have them. But you can't score them if you want to diagnose mixed features in DSM-5. Writing a little bit about this, we looked first at inpatients. And what we found when we looked at the symptom profile was that if you drew up a spectrum from unipolar major depressive disorder to bipolar disorder, indeed, distractibility, psychomotor agitation were core to the mixed state. This is just taking all the symptoms across the spectrum. Similarly, if you looked at outpatients, we found again distractibility, psychomotor agitation, and irritability were core to the mixed state, more so than other symptoms which define melancholia and mania. And it was the dip, these three symptoms kind of almost dip from mania into depression, creating that mixed state. They're the driver. So by not having them, we're losing out some specificity. Now clearly, if you treat these people with lithium, they don't have clear-cut symptoms, they're not going to respond. And one of the problems is that lithium is being prescribed to bipolar 2, to mixed states, and therefore you're getting non-response. And the inference is that it doesn't work, when actually it's being used to treat the wrong type of syndrome and wrong type of presentation. And hence we're getting an undervaluing of lithium's efficacy, when actually we should be targeting those patients that are clinically and phenotypically look more like the manic depressive illness. This here is an octahedron which shows, going right back to Weygandt's and Kreplin's formulation of mixed states. We don't have to reinvent the wheel here. They actually did the work. Weygandt's thesis, published in 1899, articulates in about 40 pages very nicely all the various subtypes of mixed states. And why that's important and why that's gold is because there were no medications at the time to color the presentation. These patients had been observed longitudinally for long periods of time without the noise of other treatments. And what they came up with was this wonderful model whereby you modeled activity, mood, and thought, and you could get these 8 presentations. The pure presentations of depression and mania, and then all these other types, manic stupor, inhibited mania, unproductive mania, etc., which are essentially combinations of these dimensions. That gives us a much richer understanding of mixed states in and of themselves. This is another way of looking at them. So if you give depressed mood or manic mood prominence, then you look at ideation or motor activity, you get all those 8 forms. Now that's not to say they're equally prevalent. We have to do research on that. And it may well be that some types are much more common, such as agitated depression, than others. But we actually are not even looking through this particular lens at the moment. And so mixed features, as it stands with DSM-5, is causing a lot of confusion and stagnation in research, is what I would argue. And it's simply too broad, too diffuse to provide us a target. If we're looking for treatments, we need a specific target rather than an amorphous, nebulous construct. Okay, so you're probably saying, okay, we understand you don't like this and you don't like that. Very easy to criticize all of this, isn't it? You get off a plane, you come over here, you keep talking about this is wrong, and you're kicking the ball here and you're kicking the ball there. Then you're going to get it back on your plane and off you go. You know, you leave us with the questions, you know, is there a bloody solution to this, or is this just your own personal psychotherapy with a group of 60 people? Well, it could be a bit of both. Is there a solution? Well, we've put forward our model. We've put some models out, but here's one other one that I'd like you to consider. We're all familiar with wires and so on, so we extrapolated from that. And if you look at a wire, and it's got various components to it, we've just been looking at mood. Mood defines both depression, mania, mixed states. We just focus on this one dimension. What if there are other dimensions like Weygand and Kreplin suggested? Activity, emotion, cognition. And we've put it specifically like this, not only because it makes the word ACE, but because it actually gives activity and cognition prominence over emotion. And emotion is broader than just mood. It encompasses other aspects as well. It's not just mood as an element in and of itself. And we should map all of those. So collectively, yes, you still can get changes, but you have to look at the components within. What's the advantage of this, you might say? Doesn't this just make it more complicated? Or are you just reconfiguring the chairs? Well, if we look at it this way, this might be the overall change, let's say in severity or functionality. And this might be the lowest change. Again, summating all symptoms. But if we look closely, and let's say we had these domains, activity, cognition, and emotion, looking at point A and point B, you find that here, emotion is the most prominent. But point B, it's now cognition that's most prominent. There's changes, subtle changes within the profile, within these domains and symptoms, which is important in terms of targeting, rather than crudely looking at saying, oh, that's the same score, they're equally unwell, they're both equally severely unwell. And that's just a first pass. It can be much more granular. We'll also learn a lot more about trajectory of the illnesses if we do this. We can use the current symptoms we have. We don't have to reinvent the wheel. We can look at the symptoms that we have and utilize them and group them into these particular emotional, neurovegetative, neurocognitive domains, and also look at those symptoms that map onto this three-dimensional model. One of the advantages of that would be that we can actually model mixed states. So here, we can get a better understanding of what a mixed state could be. It could just be desynchronization of the various domains. It's not necessarily an overlapping or coalescence of depression and mania. This forced polarity that we have may not be the right answer. It may be that just because the various vicissitudes that we normally have in cognition, emotion, and activity are out of sync. That would give us a new model for mixed states altogether. It would also explain why you can get seemingly very opposing symptoms. So in addition to looking at the clinical profile, if we wanted to work out people who are likely to be lithium responsive, we can look at those people, yes, who don't have comorbidities, have more of a bipolar 1 picture, are episodic, etc. But then start ignoring and perhaps giving less emphasis to these groups, which I think are causing a lot more confusion in defining lithium responsivity per se. So this is all very interesting, I hear you say, but what about lithium itself and its use in private practice? Now I'm going to look over to some of the chairs here in terms of getting a gauge for timing, because I haven't got, we're okay for time at the moment? Okay, good. I'm going to be talking a little bit faster now. Okay, so if it sounds like it's an African song, okay, that's why. All right? Okay, so clinical use. Now, I'm going to go quickly over this because I think other speakers are going to talk more extensively around the data. I wanted to get some of the concepts out. So lithium has a very broad set of applications across the spectrum, and we do typically look at mania, depression, and maintenance as separate phases. And it's interesting to see that it does feature very strongly in guidelines. And I'm heartened to see that actually most guidelines are littered with the use of lithium. So we have lithium throughout, but it doesn't get translated into clinical practice, is what I've been talking about. We were talking earlier about meta-analyses and in terms of their implications. And Cipriani's done quite a nice meta-analysis a few years ago looking at agents for mania. And here again, lithium does very well. This is showing acceptability and efficacy being on the vertical axis. Lithium does remarkably well. You know, this is fantastic news for this agent. We actually have the most robust evidence available for it, so we should be utilizing it. In the treatment of bipolar depression, it's less impressive, perhaps, not as potent, but this is looking at acute treatment, not long-term prophylaxis, as I've been talking about earlier. But in combination with other agents, again, it's very common. And so it doesn't seem to be possible to not have lithium as part of your armamentarium when treating bipolar disorder. And certainly this is where it comes to its fore in terms of continuation and maintenance therapy. So clinically, lithium is everywhere. It's being utilized time and time again, and quite rightly, and certainly in this particular phase of the illness. And this is the reason why, when we look at maintenance, it's outstanding in terms of its efficacy and prophylactic ability, mainly for mania, more so than depression, but still head and shoulders over other agents. So this is the area we need to be looking at and focusing on when defining a mood stabilizer, and why clinically lithium has done so well. But there always is a but, isn't there? Okay, so we like lithium for mood disorders. I think we've established that. It even has other uses, as I've said. For example, in batteries, but it's not all good news. I think it's very easy to sort of gloss over the negatives of lithium. There are some problems with it. It's definitely, in the real world setting, it does run into problems. One of the problems is neurocognition. Now, we published a lithium battery a couple of years ago, which was a set of neurocognitive tests that you can utilize to assess the effects of lithium. And we know that it affects lithium because patients often complain. I can't think as clearly as I normally did. My thinking is clouded. These are common complaints that patients will come up with. And it's the direct effect of lithium treatment. I don't think it's an effect that's caused by other factors. However, to examine it is extremely difficult. And the reason it's complicated is, first of all, the illness itself has acute and chronic effects. Phase of illness is an important factor: depression, mania, remitting, relapsing, prodromal, established illness, number of episodes a person's had, the effects of treatment itself, negative and positive. So there may well be, in certain instances, there's actually amelioration and improvement in some subscales. So it's not in all one direction. Then finally, demographic effects, age, gender, other medical illnesses, the role of smoking, drugs, alcohol. So all well and good to say this, but when you try to do research and try to distill a small signal, suddenly you're faced with this overwhelming problem. How do you, in amongst all of these things, start to work out what effect lithium has on neurocognition? So we tried to look at how you could approach it, and this is what we came up with. Something simple, straightforward. It's very complicated. If you try to put all those factors in, suddenly it becomes important to understand pre-illness, illness, post-illness, what's going to happen when you're administering the lithium, what's happening to underlying pathophysiology of the illness, and the mechanisms that the brain itself has inherent in trying to correct those changes. You then want to be able to look at those that are not modified by lithium versus those that are modified by lithium. And so each factor would have to be broken down and given some weighting accordingly. As soon as you start doing that, and to do it in a realistic way, you'd have to have a very large population because the cells become very small. So a study becomes almost a countrywide study. You can't do it in hundreds. You probably need thousands and tens of thousands of people to really get enough people in each of these cells to start working out where the effect of the agent may be specific or pertinent. And that's the challenge. So no one's going to do that. No one has the resources to do that. People want to do it. Who has the resources to do it? Pharma's certainly not going to be doing it. So this is the challenge we have with this molecule. Despite all its wonderful aspects, some of its debilitating aspects we simply cannot get to the understanding of because of the limitations of the complexity of what we're trying to unravel. Having said all of that, we did a bit of a literature review because that was a sort of a cheaper way of doing things to understand what's happening. There are some signals out there, and the red areas are where lithium probably has more effect. So processing and psychomotor speed, verbal memory, and verbal fluency. And these are the types of tests that can be utilized. So if we pick out certain tests from the battery and apply these routinely in our patients, over time, you might be able to amass enough data to start looking more meaningfully at seeing whether there's improvement. It still wouldn't be ideal, certainly wouldn't be able to account for all those other factors, but at least at the start. And so this was our lithium battery. This was our battery of tests that you would use for research. And this is our clinical questions that we thought are relatively easy and straightforward for clinicians to ask in routine assessments, because often cognition isn't even asked about. Clinicians certainly don't go seeking cognitive problems when they're prescribing lithium. It's usually left to the patient to volunteer that problem rather than us actually providing a rubric or questions that elicit these responses. And I said measuring lithium was a real advantage. One of the things that I think has been overstated is the risks of having blood tests, the inconvenience of blood tests, and what that's allowed is many other agents to come on board where we have no idea whether the person's actually getting a therapeutic dose. It sounds like a very fundamental question. We assume that because it's being prescribed, the person should be taking it. But we know that compliance with medication is appalling. People do not take medications as prescribed, full stop. On top of that, the complexity of each individual's pharmacokinetics and pharmacodynamics means that just working around what the norm should be gives us no indication of whether the same level is being achieved in every individual that we prescribe. So actually having an agent that you can measure is hugely important. And I look at that when I see patients when I treat them with lithium. Very rarely do I give them the therapeutic dose and get the therapeutic level in the blood. Almost always there's some variation that needs to be made. either an increase, a decrease, a change in diet, fluid, and so on. So that means that must be happening with all the drugs, not just with lithium. So actually it's an advantage that we can measure lithium, and it should be done properly. And if we look at various guidelines, they give all sorts of recommendations, but they don't actually talk about measuring lithium in the same way that we are trying to sort of put forward. So this was published about 7 years ago. The lithium meter have been trying to champion this because it's easy to utilize. It's had some clinical gain with very simple indications for initiation and maintenance, what to do to counteract mania and depression, and also what to look for in terms of complications and toxicity. Measuring is certainly knowing. By actually knowing what you're dealing with, it has a huge amount of benefits. One of the things we also forget about, though, is that we're measuring only the serum levels. And the serum levels are very different to the levels within the brain, and there's also a lag in terms of that. So getting overly concerned about changes in the serum, probably not appropriate, because the brain levels change relatively slowly and are much more steady. So sometimes, changes in the plasma level, one doesn't have to be too excited about, as long as overall the person is achieving an adequate serum level over a period of a week or so. The brain level is less likely to be as volatile. And what other benefit that has is treatment adherence. We can actually monitor treatment adherence and compliance directly, and that clearly has a benefit on plasma levels. The other benefit of measuring is that we actually start monitoring. And lithium does require monitoring. It does have some side effects. It does have problems in terms of thyroid function, in terms of renal function, and other complicated side effects, all of which are better managed if we know what the person is taking. So measuring is absolutely fundamental to that. And this is a schematic showing all the various areas that lithium can impact. The kidney, obviously, everyone knows about, the endocrine axis, thyroid function, and so on. And these are things that can all be managed if we actually know what we're doing. So we need to be able to measure lithium accurately and do it more aggressively. And so we had a second version of the lithium meter, which is far more complicated, and the subsequent slides just go through breaking that down. And I'm not going to talk to these because these are relatively straightforward. But the complexity of lithium can be broken down quite easily. I want to spend the last few minutes just talking about mechanisms and talking a little bit about where we're going in terms of understanding its function. So I've talked about mood, I've talked about cognition. Question then is, what is it actually doing on structure of the brain, neurotransmission and cellular changes? And does it actually have effects on the brain architecture? This was a study by Hallam, published in Biological Psychiatry in 2011, very nice study, which showed that lithium has somehow managed to increase the size of the hippocampus, more so than even normal. This is the normal population here on the left. These are people not on lithium in the middle. But people on lithium seem to have some protective effect. And this wasn't unique to hippocampus, it was hippocampus and amygdala. But this is a gross volume, this is not specific cellular physiology, so there could be all sorts of reasons for that. But the fact that you can actually get a localized change in the brain because of a molecule, quite exciting. It means it may well be a basis to its neuroprotective effects. If we look at neurotransmission for that, we see that lithium does have a very active engagement of glutamate, dopamine, and GABA, both at the cellular level, but also second messenger systems. And this is really quite complicated. But it also gives us an inroad into understanding how its effects are modulated first at the cellular level, but then at the cognitive level. So we see the neurocognitive effects, we see the clinical effects, and for most molecules, we have no understanding of the translation of the basic science to that clinical science. But here we have a molecule that we actually understand the intracellular processes and molecular processes quite well. So we can, for once, do that translational bridge that we often talk about. It's a very complicated bridge. There are a lot of molecules and a lot of targets, but that in itself shouldn't be off-putting. What we really need to be doing is coalescing our ideas around this, and many groups are doing this very well now, and also linking it to genetic studies to try to find which proteins, which particular enzymes are key in terms of translating lithium's effect on a cellular second messenger system into a clinical effect. I won't go through the whole list of things that have been found so far, but all of this is very exciting. This is actually giving us a deeper understanding of why lithium does all the things I've talked about. What is the actual fundamental basic neurochemistry of this molecule? And it's complicated, as you would imagine, but it's also clear that it has a profound effect on a number of processes which ultimately lead to changes in the brain. And here we have connection from these areas right down to neuroprotection. This isn't my slide. This is being copied from another paper, which brings all of this information beautifully together, though it's complicated. Sorry. All right. So integration of these mechanisms is what we need. And one thing we can do as a practical aspect, as mentioned about the suicide aspect, is look at suicide more specifically. Now, do forgive me, I'm going to jump through a few slides which talk a little bit more basically about suicide, but I'm mindful of the time. I certainly don't want to go over that. And the key slide I want to get to is around the model that we've looked at recently. We all know the difference between suicide and self-harm, but this is the model of suicide. Suicide's an event. It's the end stage. It's obviously a horrible, disastrous outcome. But it's a process. It's not just the event. Suicide, people build up to it. And it's a lot of other steps, some stemming right back to the genetic neurobiology and makeup of the person, through to their current mental state, and then what's happening in their life and how they appraise that, and what are the steps that lead to it. We need to be able to break it down into these steps, dismantle that, and understand where there are opportunities for intervention. So alongside this model, which is specific to mood disorders, we need to be able to identify where treatments particularly work. And that's where lithium perhaps has some benefit, particularly in preventing suicide at a population level. And why I say that is there is some research showing that even small levels of lithium in the water seem to have some correlation, I emphasize that word, correlation with lower rates of suicide. We don't understand why that's the case. There may be another factor, but it may also be that lithium is a causative factor in that. If that's the case, that's quite profound. So what happens in someone who's developing suicidal ideation? Well, first they have a number of risk factors, and there's obviously interaction of those risk and vulnerability factors, which leads to changes in their appraisal system. And the appraisal system is really important. It's how we understand who we are, where we are, what we think, how we think about the world, and also project ourselves into the future. If that's all negative, and we see it as helpless and hopeless, then obviously that's going to lead to the inception of suicidal ideation. So we have sense of defeat and entrapment. This leads to suicidal ideation, intent, and ultimately an attempt which may or may not be successful. So it's a process, and this is why it unfolds, sometimes over days, sometimes over weeks, going from step A right through to suicide itself. And there are a number of factors that we can identify that drive that process, which can all be collated as a prevailing cognition. This negative drive, all of them being constantly added to at each step, leading ultimately to suicide. At the same time, it also provides us opportunities where at each of these steps we could perhaps intervene, both psychologically or pharmacologically, and change that process, stem it in some way. At the moment, the way suicide is being managed is rather poor. What we do is we say people tend to sometimes jump in front of trains. So let's put fences in front of all platforms. Let's board up all bridges. And that's only really ever going to help at this particular point, at the point of an attempt. And it's transient. It doesn't actually respect the fact that there's a lot of other factors that are perhaps amenable to change. And clearly that's the way we need to be going forward. So we did a study of suicide using fMRI and used both the emotional Stroop and the GLM method of analyzing that data. And what we found was quite interesting. These are patients who had mixed states, characterized as the way I've been describing them, not as bipolar 2, bipolar 1, looking very closely at their mixed states. And we gave them a fairly standard paradigm of incongruence between a happy face and a word. So you can get happy face plus negative word, or you can get a sad face and a positive word. And the idea was to create a mixed emotion. And that incongruence taps into a certain part of the brain and the emotional system and sets off this idea of having to be making a decision as to what's the dominant emotion that you relate to. And that's obviously going to be also dependent on your current emotional state. And predictably, the types of areas that you'd expect activated. But what was really interesting was that there was a divergence in the dorsal default mode network, which is an area which really is a sense of, gives you a sense of self. It's an understanding of yourself in the broader world, and it has a number of other functions as well. But in contrast, the basal ganglia had an increased activation. And we know that this is a motivational aspect. This is an area that is driven in terms of drive towards any kind of acting and planning. And we tried to dissect this further. I won't go into the sort of nuances of that, but this diagram actually shows it quite nicely. That in terms of clinical correlation, the changes in the basal ganglia, sorry that's come up that way, that should be an arrow upwards, and that's an arrow downwards. You have a correlation with ideation. But the dorsal DMN activation was correlated with behavior, all captured with the suicide scale in the past month. So this is sustained suicidality. It's not impulsivity. It's not to do with an immediate idea of suicidality. It's suicidal thoughts and ideation over a period of days and weeks, building up to the planning of an event. And that was really quite interesting because that showed us that incongruence is the driver. And so building on that, we've worked out, and we've published this recently, that lithium possibly, in addition to the ones we already know, neurobiological mechanisms, also addresses these endophenotypes: aggressive impulsivity, disadvantageous decision-making. Now, this is something that actually can be tapped into psychologically. We could actually modify in individuals prior to them leading to a suicidal event. Negative cognitive appraisals, another opportunity to intervene early, ultimately leading to suicidal thinking and behaviors. I'll skip over these last two slides because it really just reiterate what I've said. My main point with this particular study is it's one small study. It's a very preliminary finding. I'm not hanging anything on this at all. But it's moving towards getting a link between the molecular mechanisms, the neural networks, and the clinical scenario that we're faced with, and using lithium to actually connect them, driving our understanding, because we do know a lot about the molecule, and we're not utilizing that, using it in different contexts to make that a link. So lithium is the king of mood stabilizers, but the monarch, like all monarchs, needs an heir. And we need to be looking at that by understanding its neurobiology, certainly putting a lot more effort into refining our diagnosis, conducting clinical research in far more homogeneous groups so that we can identify what determines lithium responsivity. And I think we can all agree, we like lithium, we need to use it more, but what we need more is lithium-like molecules. Thank you very much.